think we'll give it 5 more minutes for more people to join, and then we'll start.
Sure. Hello everyone, welcome to the Zoom meeting. Today the Blue team will present some of the topics. Thank you for joining, and Dr. Salah will moderate the meeting. When you have a meeting, I'll hand it over to you, Dr. Salah. Thank you.
Welcome, Dr. Nader. Thank you.
Welcome, Dr. Nadir.
Welcome, Dr. Nadir. Thank you.
I'd like to welcome all the new fellows to the program. And usually on Saturday, we will have our meetings, and we divide the group into small teams. So each team will be working to present some of the topics. Welcome everyone. And we're going to start when you are ready. Hello, and thank you.
Okay, we'll start by the presentation by Dr. Monir Hamad about heart failure. Are you ready, Dr. Monir?
Yes, I'm ready. I want to share my screen. I hope everyone can see the screen.
Yes, it's already shared.
Okay. Can you hear me?
Yes. Yes.
Yes.
طيب. Bismillah ar-Rahman ar-Rahim. Today we are going to talk about heart failure, which is one of the most common chronic disease in cardiovascular. So the objective of my talk today, we'll talk about the epidemiology, the clinical picture, the management, and then I will talk about the end-of-life care. The topic will cover, as I said, the epidemiology, the etiology, the diagnosis, the management.
Excuse me, Dr. Moore. I think we have the blank screen. So if you can unshare and then share either the whole window or the specific program.
Okay, I'll see.
Yeah.
Is it clear?
Yes.
Yes. Thank you so much.
Thank you.
Okay, so again, the objective is to talk about the epidemiology, the clinical picture, the management, and the end-of-life care. So the topic will cover the epidemiology, etiology, diagnosis, prognosis, and end-of-life care. Epidemiology of heart failure, the incidence and prevalence increase with age. As you may know, most of the disease increases with age, but specifically heart failure more common. It is a leading cause of hospitalization and rehospitalization in elderly populations. The median age of patients hospitalized with heart failure is 75 years, and approximately 2/3 of deaths attributed to heart failure are patient age above 75. So heart failure is the major cause of chronic disability and impaired quality of life. The etiology of heart failure is multifactorial. The commonest cause is hypertension. As you may know, 60 to 70% of women who have heart failure, the cause is hypertension, and it's also attributed to 30 to 40% in men. This is along with coronary artery disease. Similar proportion is attributed to coronary artery disease. Other common cause of heart failure is, as you may know, valvular heart disease, non-ischemic dilated cardiomyopathy, and there is many other causes. But these are the commonest cause. So the definition of heart failure, actually, this is not a definition. This is the classifications. The definition is a failure of the heart to give an adequate blood supply to the tissue. But the classification, there is many classifications of heart failure. The commonly used systolic heart failure, diastolic heart failure, HFrEF, HFpEF, and this is why they classified into that, because the management will depend on this classification. So if you are talking about systolic heart failure with reduced ejection fraction, up to 30%, up to 90% of heart failure patients less than 65 have this form of systolic dysfunction. Heart failure with preserved ejection fraction or heart failure with ejection fraction more than 50 affect around 40 of men and around 2/3 of women who is above 65. I don't want to complicate the things, but there is another in between. There is heart failure with reduced ejection fraction, which is less than 40, and heart failure with preserved ejection fraction, which is more than 50. Somebody will ask me, from 40 to 50, where are they? So there is what is called heart failure with improved ejection fraction, heart failure with mildly reduced ejection fraction, in between. Forget about that. Why? Because in the management, we have heart failure with reduced ejection fraction, which is less than 40, and this is special category and has a special treatment. Heart failure with preserved ejection fraction with ejection more than 50%, this is another category. So I put a slide called classification. Classification of heart failure may be into acute or chronic heart failure, maybe into systolic or diastolic heart failure. Maybe I can call it left heart failure and right heart failure. And maybe I can stage it into stage A, B, and C, and D according to the risk, the structure, and symptom, and refractory symptom. But the commonly used is heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. The other commonly used classifications, which is the stage of heart failure, into class A, B, and C, and D. A, the people at risk, the people who have hypertension, diabetes, and they have no structural heart disease. This is class A. The one who classified B is the one who have structural heart disease, but they have no symptom. Class C, the one who have symptom and sign of heart failure currently or previously. And class D is a refractory symptom, patient who has heart failure and they are refractory. So what are the symptoms and signs of heart failure in elderly populations? As you may all know, heart failure came with dyspnea, shortness of breath, fatigability, or orthopnea, leg edema, and so forth. But in elderly population, the symptom may differ. They may come with a symptom of decreased mental acuity, confusion, lethargy, irritability, anorexia, abdominal pain, which is not the typical symptom of heart failure we know. So we have to take care when we are treating an elder population. How I'm going to diagnose heart failure? Diagnosis usually starts with symptom and sign, and then investigation. In the investigation, I will start with the standard chest X-ray, AP and lateral X-ray. This is the standard for heart failure. To see in the X-ray, the pulmonary congestion, the pleural effusions, and also I use BMB, which is B-type natriuretic peptide, and it is precursor also. Sometimes we use N-terminal pro-BNP to evaluate heart failure. If you have a symptom and you are confused to distinguish between short of breath due to heart failure from other cause, BNP is the most important parameter. But take care. The specificity is decreased with age. And also, the BNP is low in obese patients. This is the only 2 points that you have to take care when you are using BNP. Otherwise, it is very important parameter in diagnosis of heart failure. Before I go to management of heart failure, I need to elaborate more on something else. I need to go back. Yes. So heart failure in diagnosis, also I can use echo. Echocardiography is very important parameter in diagnosis of heart failure. Why? Because I can see in the echo the LV function, the systolic function, the diastolic function of the heart, the valve, and the regional wall motion abnormality. And from there, I can know what is the cause of heart failure. And also the prognosis can depend on the finding in the echo. The management of heart failure. The goal of management of heart failure is to decrease the symptom, improve the quality of life, and reduce exacerbation and rehospitalization, and also increase survival. So when I'm talking about to treat the underlying cause, I'm talking mainly about hypertension, hyperlipidemia, diabetes, all should be treated concurrently with a guideline according to the guideline for each. And also smoking cessation should be strongly encouraged and supported if indicated, and alcohol intake should be limited to no more than 2 drinks per day in men and 1 drink per day in women. So the treatment is classified into 2, pharmacological and non-pharmacological. For the non-pharmacological, I'm talking about restriction of salt, which is less than 2 grams per day. And also the most important things in heart failure is regular exercise, such as walking or cycling or swimming. And exercise duration is very important in the management of heart failure. So patients should keep an ongoing records of their daily weight. Also, this is the most important things in management of heart failure. You have to know the weight. The pharmacological treatment of heart failure, as I said before, systolic and diastolic. So when I'm talking about systolic heart failure, because there is a lot of guideline-directed medication for systolic heart failure and approved by trial. For diastolic heart failure, maybe a little bit different. So optimum treatment usually requires 3 or more medications, and in some cases up to 7 medications. Almost all patients take more than 1 additional medications for coexisting illness, as I mentioned before, diabetes, hypertension, and so forth. So what is the problem of the pharmacological treatment of heart failure? The problem is the adherence, the high potential for drug-drug interaction, and adverse effect of the drugs, and the cost of the drugs. You have to consider all this when you are treating patients with heart failure. So therapy must be individualized, taking into consideration multiple factors that influence quality of life and other desirable clinical outcome in older adults with multiple chronic illness and limited life expectancy. I will start with ACE inhibitor, which is one of the cornerstone in treatment of systolic heart failure. When I'm talking about systolic heart failure, I'm talking about ejection fraction less than 40. So in general, start treatment at the lowest dose ACE inhibitor and gradually titrate to maintain the dose as tolerated. What is contraindication for ACE inhibitor? One of them is intolerance to this agent, or the patient who has hyperkalemia, the patient who has severe renal insufficiency and is not currently on dialysis. You have to take care. The common adverse event of ACE inhibitor is cough, which is found in 50 to 10% of populations. Hyperkalemia also is a cause. Hypotension, anxiety disturbance. And sometimes there is angioneuritic edema in certain patients. ARBs are an option for heart failure patient who is not tolerated ACE inhibitor because of cough or some allergies. ARBs is a receptor blocker. Aldosterone angiotensin receptor blocker. Beta blocker, the second step in the management of systolic heart failure. Even if the patient is asymptomatic, NIHA class 1, with ejection fraction less than 40, you can start ACE inhibitor and then you can add beta blocker. So as with ACE inhibitor and ARBs, treatment should be started at the lowest available dose and gradually titrated to maintain the dose over several weeks. Are you following me?
Yes,
Yes,
Dr.
yes, Dr. Monir.
Yes. Yes.
Okay. So what is contraindication? Contraindication include severe decompensated heart failure, active bronchospasm, marked bradycardia, or hypotension, or if there is an AV block, like first degree, second degree heart block, or third degree heart block, is contraindication to use beta blocker, or if the patient is not intolerance to beta blocker. I put this slide from my own. It is not in the presentation because the presentation a little bit, I think it is an old version, but what is new about heart failure is there is medication apart from ACE inhibitor and beta blocker you can use. Initially, optimize therapy with either beta blocker, ACE inhibitor, or ARBs. Instead of ACE inhibitor or ARBs, I can use a combination of angiotensin receptor blocker and neprilysin inhibitor, which is called Entresto. This is new medications. Can be used, all this together can be used in NIHA class 1. That means there is no symptom, up to NIHA class 4, which is severe refractory symptom in a patient who has ejection fraction less than 40. Why? Because all this drug, like angiotensin receptor and neprilysin combination Entresto, slows the disease progression and improve quality of life. Beta blocker also improves the quality of life. But diuretics, usually for a symptomatic patient who is class 2 and above, like loop diuretics, as we know, which is called furosemide, commonly used, plus or minus metolazone, which is thiazide diuretics, potent thiazide diuretics. Diuretics improve the symptom and reduce hospitalization, but they have no mortality benefit. You have to use it, but they have no mortality benefit. So what is the step 2 in the management? Step 2, if the patient is still symptomatic, NIHA class 2 and above, with ejection fraction less than 35, you can use aldosterone antagonist. Why? Because it reduces the hospitalization and improve the quality of life. Step 3, you can use SGLT2 inhibitor, like dapagliflozin, one of the example of them, in a patient who has class 2 and above heart failure. That means symptomatic patient. Even if he's not diabetic, you can use it. Why? Because it improves the mortality and it reduces the symptom. The last two medication, what I can call it supplementary agents, like digoxin and isosorbate dinitrate combination with hydralazine. We all know in the old teaching, digoxin one of the cornerstone in heart failure. However, all the studies show that digoxin reduces the hospitalization, but it has no mortality benefit. Isosorbate dinitrate hydralazine combination used in the patient who is intolerable, cannot tolerate ACE inhibitor, especially in a black populations. It improves the symptom. It may improve quality of life. So let me talk about diuretics again for systolic heart failure. Diuretics is essential component of heart failure therapy in most patients. It is most effective agent for relieve the congestions and edema and the symptom. But as I say, has no mortality benefit. In general, diuretics dose should be adjusted to maintain euvolemia. Manifested by absence of pulmonary rares, S3 gallops, decrease the jugular venous pressure, absent hepatojugular, and decrease peripheral edema. This is a parameter that I follow in a patient who has heart failure. Commonly, we follow edema, subside, and JVB also, and there is no congestion after you give diuretics. Then aldosterone antagonist, also used for systolic heart failure, as I mentioned, in the patient who has class 2 and above, with ejection fraction less than 35. Aldosterone antagonist, spironolactone, this is one of the examples, has been shown to reduce mortality and hospitalization in patients with NEHA class 3, ejection fraction less than 30, and in NEHA class 2, even if the ejection fraction is less than 35, as I mentioned in the previous slide. What other option for aldosterone antagonist? Abdelrahman, selective aldosterone antagonist, had been associated with improved outcome also in patients with recent MI complicated by heart failure or ejection fraction less than 40. Other therapy for systolic heart failure, as I mentioned, digoxin. So digoxin improves the symptom, reduce heart failure hospitalization in patients with chronic systolic heart failure, but has no effect on mortality. Adverse effect of digoxin, as all you may know, nausea, visual disturbance, cardiac arrhythmia, especially in elderly population. The combination of hydralazine and nitrate is recommended for patient contraindication to ACE inhibitor or ARBs in Black populations with advanced heart failure who has still symptomatic as an adjuvant. As an adjuvant to ACE inhibitor and beta blocker in Black population, this is maybe benefit. And also if the patient is not tolerated ACE inhibitor or contraindication to give ACE inhibitor. Let me move forwards to talk about pharmacological treatment for patients with preserved ejection fraction. Optimal therapy remain undefined. If the patient is ejection fraction more than 50%, there is no guideline-directed therapy for it. You have to treat with diuretics, you have to treat the underlying cause, but there is no role for ACE inhibitor, there is no role for beta blockers or any other drugs, because many trials have been done on this and it was negative trial. So the current recommendation for HIF, what is called HIF-BEF, preserved ejection fraction, is aggressive treatment of hypertension and other comorbid condition, and maintain the rhythm if the patient had arrhythmia, and judicious diuretics to maintain euvolemia. That is all about HIF-BEF. And HIF-BEF is more common in women, elderly, above 65, and usually it is a stiffness of the ventricles. The ventricles cannot relax to accommodate the blood. So it is preserved ejection fraction, but with impaired relaxation. What I'm going to add for a patient who have refractory symptom, if I use all the guideline-directed medical therapy and still my patient is symptomatic, I have to go further for intervention like implantable cardiac defibrillator. It reduces mortality from sudden cardiac death in patient who has systolic heart failure, ejection fraction less than 35, regardless of if it is due to ischemic heart disease or non-ischemic heart disease. This is the implantable cardioverter. So I can use it as prophylactic in patient with NEHA class 3 and above, with ejection fraction less than 35, and the life expectancy should be more than 1 year. So I cannot put an ICD for patient life expectancy less than 1 year. So in acute MI, I can defer the ICD implantation for more than 40 days after acute MI and more than 90 days after new diagnosis of dilated cardiomyopathy. Why? Because in the later case, LV function often improve after initiations of beta blocker and ACE inhibitor. If not improve and the patient is symptomatic, then I can go to put an ICD for those patients. This is X-ray of the ICD. So in the ICD, you have the lead will go directly. This is a battery. The lead will go directly into the RV, and this is in the RV. This is the shockable device. It is here, and there is connected with another lead, small lead in the atrium So it's connected with pacemaker. But the main function is an ICD. It gives the shock for the heart if there is tachycardia. So it apports the tachycardia. The other things I can use is cardiac resynchronizations, which is a device similar to the ICD, but a little bit different in the location. So it is called biventricular pacemaker with one lead in the right ventricle, the same like the ICD, and the second lead inserted retrograde into the coronary sinus to estimate the LV ventricles. Why? Because I cannot go directly in the LV. The LV is very strong. If you put a lead in the LV, it will be break. So you put the lead in the coronary sinus so as to give a shock to the left ventricles. Indicated in patient with desynchronous LV contraction. And here we have to know who is desynchronous. Most commonly related to the left bundle branch block. It present in up to 30% of patients with systolic heart failure. So it improves the symptom, exercise tolerance, quality of life, and survival in selected patients with advanced systolic heart failure, ejection fraction less than 40. It's mainly less than 35 indicated. And NEHA class, you can start it from NEHA class 2 and above. And the ECG is very important here. So one of the criteria to have class 1 indication, if you have left bundle branch block with a QRS duration of more than 150. This is absolute indication for resynchronization therapy. And this is also an X-ray of the device. I hope you can see the lead in the RV, all you can see it, I think. But the other one in the coronary sinus, if you look at there is a lead in the coronary sinus so as to shock the LV, because you cannot go inside the LV directly. Recurrent hospitalization. One of the problem of heart failure, which is very cost effective, the hospitalization every now and then. Up to 50% of patients with heart failure are readmitted within 3 to 6 months after initial hospitalization. I hope I didn't go beyond my time, moderator. Am I in my time still?
Yes, that's fine. Go ahead.
Okay. So patients who experience recurrent heart failure hospitalization within 3 to 6 months after an index of admission should be questioned carefully. About what? You have to look at the adherence of medication. Is he taking medication regularly? Use of the out of the counter medications like non-steroidal anti-inflammatory or something like that. Recent change in the weight, recent dietary choice, especially if you take salt, and the daily fluid. You have to take all these parameters when you are managing patient who had recurrent hospitalization. What is the prognosis of heart failure? The median survival of heart failure rate 2 to 3 years. 25 to 30% of patients die within 1 year after initial diagnosis. 50% survive 1 to 5 years. 20 to 25 survive more than 5 years. So a woman and patient with HFpEF have somewhat better survival rate than men and patient with systolic heart failure. This is very strange. You know, HFpEF, they have no guideline-directed medical therapy, but still the prognosis is better than HFrEF. End of life. End of life care, I think, can be applied to most of the chronic illness, not only heart failure. So you need to counsel regarding advanced directive, durable power of attorney for healthcare, elicit instructions about what intervention they would or not or wish to undergo if this appear imminent. In heart failure specifically, we are concentrating on the device mainly. Ask the patient with ICD to indicate under what condition they would want the ICD to be turned off to avoid repetitive shock, painful shock. By the way, the shock is very painful. In patients with particularly poor prognosis and remaining life expectancy less than 6 months, frank but empathetic discussion should be undertaken with the patient and family. In summary, heart failure is the leading cause of hospitalization in elderly people and a major source of chronic disability. ACE inhibitor and ARS, beta blocker and aldosterone reduce morbidity and mortality from heart failure. Optimal management of heart failure in elder patients is require multidisciplinary approach. So let us go through these two cases as quickly as possible. This is a 78-year-old man, no significant medical history, come to the emergency department with severe chest pain, 3-hour duration, associated with shortness of breath. Initial ECG finding showed 4 to 5 centimeter segment elevation. I think now the diagnosis is clear for all of you. So an ST depression in 2, 3, and AVF. Emergency cardiac cath reveal 100% occlusion of the left anterior descending artery just after the first large septal branch. So percutaneous angioplasty with insertion of a stent into the left anterior descending artery was successful. The peak troponin level 8.6. The hospital course is complicated by mild heart failure that resolved with diuresis. Pre-discharge echo revealed an anteroapical hypokinesia with mildly decreased LV systolic function. Estimated ejection fraction is 45. Oh, yeah, this is a question here. So, on day of admission, a total cholesterol is 186, HDL 47, LDL cholesterol 113, triglycerides is 130. So, in summary, before I go to the option, the patient has acute myocardial infarction. He underwent successful revascularization. And currently, he has no symptom. Ejection fraction is 45. And we know that in the guideline, should be 40, okay? So, in addition to aspirin, statin, and clopidogrel, which of the following are the appropriate discharge medication for this patient? Beta blocker and long-standing nitrates, beta blocker and spironolactone now, non-dihydropyridine calcium antagonist and ARBs, beta blocker and ACE inhibitor, non-dihydropyridine calcium antagonist and long-acting nitrates. I think by exclusion, you can answer this. I don't know, how can I see your share for the answer? Is it possible to see?
I think it's D.
In the chat.
In the chat, okay, thank you. In the chat, so how can I open the chat while I'm presenting my case?
You will find it on the user interface in the middle.
Okay.
You can go top of the screen also.
This is a chat, yes. Now I open the chat. Okay, so most of you say D, and one say B. Let me go back. Okay, agree with you, D. Why? Because there is no indication for long-acting nitrates. The patient is asymptomatic and he's revascularized. Spironolactone may be the next option. Non-hydropyridine calcium antagonist is not an option. Usually it causes reflex tachycardia. I agree with you. It is beta blocker and ACE inhibitor. In spite of, there is no absolute indication. Why? Because ejection fraction here is more than 40. But still beta blocker has role post-MI. and ACE inhibitor, I think, is good option. By exclusion, I will give this answer, but it is not an absolute answer for me. I'll go to the next question, which is the last one. 74-year-old woman come to the emergency department with palpitation, shortness of breath of 2-hour duration. Her history include hypertension, myocardial lung disease, gastroesophageal reflux, and positional tremor. She said she was sitting in the chair when she noted sudden onset of heart racing, following a few minutes later by difficulty breathing. She reported no chest discomfort, diaphoresis, dizziness, or syncope. When the symptom did not resolve after an hour, her son brought her to the emergency department. So what is the main symptom? The main symptom is palpitation and shortness of breath for 2-hour duration. On examination, the patient is in mild respiratory distress, heart rate range from 130 to 150, which is irregular, blood pressure 140/70, respiratory rate is 22, neck is supple and normal jugular venous pressure and no thyromegaly. The lungs are clear. The heart is irregular with 2 out of 6 systolic ejection murmur and no S3 or S4. She has moderate positional tremor. ECG show an atrial fibrillation with rapid ventricular response, LV hypertrophy with repolarization abnormality, no ischemic changes, chest X-ray, mild cardiomegaly, no infiltrate, so the patient is not in heart failure. The Salim scan, it showed LV ejection fraction of 67 with no evidence of ischemia, and echo show moderate LV hypertrophy, mild left atrial enlargement, normal LV systolic function, and mild LV diastolic dysfunction. So, very long, sorry for that. The cardiac marker is normal, creatinine is normal, and all other lab is hemoglobin A1C a little bit 7.3, and cytotropin is 2, cholesterol a little bit high, 198, and so forth. So the patient is treated with diltiazem with subsequent reversion to a sinus rhythm. Intravenous furosemide result in net diuresis of 1,000 plus ml. MI excluded by normal serial troponin. Which of the following are the appropriate discharge medication for this patient? I will read the answer and then I will see your response. Aspirin, warfarin, amiodarone, ACE inhibitor, warfarin, diltiazem, beta blocker, aspirin, beta blocker, ACE inhibitor, statin, warfarin, beta blocker, ACE inhibitor, ARBs, diltiazem, beta blocker, and ACE inhibitor. So let me summarize the case so as to be in the same page. The patient is 74, and this is CHA2DS 1. Okay, there is no heart failure, and there is no diabetes, there is no stroke or anything else. So to calculate the CHA2DS, I think it is maybe 1 or 2.
No,
1 plus
she's
or 2, something like
hypertensive and she's a woman. So for a woman, she get 1. For hypertension, she get 1, and for her age, she get 2. So that's almost 4.
No, for age, she will get 1 because age above 75 will get 2. So she's 74. For the
Okay,
age, she will get 1.
Okay,
For
woman
the woman, she will
1,
get 1.
and
Agree with you.
hypertension is 1.
And what
Okay,
about
good.
hemoglobin A1C 7.3?
Yeah.
Hemoglobin A1C 7.3, the patient is not diagnosed before at. So if you calculate that 2 plus, or you can say 3, woman, age 1, and hypertension at least 3, and 3 plus. So what is the option? Are you going to give her aspirin, warfarin, amiodarone, ACE inhibitor, warfarin, diltiazem, beta blockers, and ARBs, aspirin, beta blocker, ACE inhibitor, and statin, warfarin, beta blocker, ACE inhibitor, and ARBs, diltiazem, beta blocker? I want to see the response. A, E, totally apart.
If it, we can see,
The answer
can we see
which
that?
is mentioned here, the answer which is mentioned here, actually, I'm not convinced about.
It's gonna be C.
because they mention cannot be C. Yeah, they mention aspirin, beta blocker, ACE inhibitor, and statin, and they did it put her on warfarin. So this patient should be on warfarin. The best option for me, I can use D, which is warfarin, beta blocker. Oh, combination of AC and ARBs is not there. Also, it's not preferable. So. A warfarin, deltazine, beta blocker, and ARBs, maybe B. Maybe B is better. Yeah, B is better option. But still in B, you find deltazine and beta blocker. Combination of them is not good to combine deltazine and beta blocker at the same time.
Can I just interrupt?
Yes, you have a comment, Dr. Nadir?
Yes, these slides are used from the previous couple of years, so I don't think we have the updated slides from the AGS, so we can ignore the answer.
We can ignore the answer.
Yes. Yeah. So
yes, I agree with you totally.
The explanation can be helpful.
Yes, the explanation is the patient had CHA-2DS2, which is 3 and above. If the CHA-2DS2 is 3 and above in a female, you need to give anticoagulation. If it is below 3 in a female, it is controversial. For the male, if it is 2 and above CHA-2DS2, you have to give an anticoagulation. If it is below 2, from 2 to 1, is controversial. Less than 1, absolutely not indicated. This is the message from this question. Thank you so much for listening. I want to apologize for 2 things. I take a long time and my accent is not that fluent or good in English. I'm so sorry for that. If you have any questions, you can ask me.
You did great, Dr. Munir, actually.
Excellent.
Thank you.
Thank you so much. Thank you so much, Dr. Monir.
Thank you so much for you.
Yeah, you did excellent, wonderful presentation. It's an important topic, and everyone should know, especially the updated guidelines as far as what to do with medication and so forth. Thank you.
Thank you, Dr. Monir. Great presentation. We'll take some time if anyone has any questions.
Welcome.
I don't think there is any questions, so we'll move on to the next presentation. Dr. Hamida, are you ready?
Yes, I'm ready.
Okay.
You can hear my voice? You can hear me?
Yes. Go ahead. The next presentation is post-ortho procedure DVT prophylaxis.
Of course. I want to share my screen. I cannot. Please allow me to share my screen. You cannot start screen share while the other participant is sharing. You need to stop, Dr. Munir. Let me.
Did I stop sharing?
Not yet.
I'm not very familiar with this technology, but
Can you try it again?
Okay, sure.
Now am I clear out?
Okay, let me check. No, you can see my screen?
Yes.
Okay. First of all, thank you so much for being here today. And I would like to thank Dr. Nader for being patient and for being commitment to each Saturday's session. I know today was a long day for you, Dr. Nader. So thank you so much for your time and for your effort. I'll start. So my presentation is about post-orthopedic procedure prophylaxis. I will start with some definition, DVT and pulmonary embolism. So DVT occurs frequently as a common and a serious complication after orthopedic surgery, especially when knee and hip replacement, spinal operation, or osteosynthesis for sciatic surrounding bone fracture have been taken. Deep vein thrombosis is a formation of a blood clot within a deep vein. It's commonly occur in the thigh or calf. DVT can develop after any major surgery. People who have surgery on the legs and hips are especially at risk, as I mentioned before. On the other side, the pulmonary embolism is a blood clot that breaks free and travel through the veins. If it reaches the lungs, it can block the flow of blood to the lung and heart. A pulmonary embolism is a dangerous condition that can even lead to death. We're going to start with the prophylaxis for venous thromboembolism. One of them is DVT and the other one is pulmonary embolism. We're going to start with the mechanical methods for VTE prophylaxis, which include number one, mobilization, number two, gradual compression stocking, number three, intermittent pneumatic compression device, number four, venous foot pump. We're going to start with the advantages of mechanical prophylaxis. Number one, lack of bleeding potential. Two, no need for laboratory monitoring and no clinically important side effects furthermore. Number three, the effectiveness of anticoagulant may be enhanced by some mechanical methods, in particular, intermittent pneumatic compression devices, which stimulate endogenous fibrinolytic activity by reduction of plasminogen activator inhibitor 1 levels. This kind of method can prevent VTE incidence. The disadvantage of mechanical prophylaxis, number one, the difficulty of implementation or suboptimal compliance issues due to limited movement of the patient and the discomfort they may bring. Two, needs to be worn continuously pre, intra, and post-operative for 22 hours. The third one is a lack of powerful evidence that any of the mechanical VTA prophylaxis methods may reduce the risk of death or pulmonary embolism, which are fatal, as I said before. Number four, concerning of compression stocks, these need to be sized and fitted properly, while it has been reported that they can cause impairment in tissue oxygenation. The fifth one of disadvantage that situations such as open fracture, peripheral arterial insufficiency, severe cardiac insufficiencies, and infection and ulceration of our lower limbs are contraindication for the use of mechanical VTE methods. I will talk a little bit about mobilization after surgery through early walking. Mobilization is through early walking is probably the most simple and applicable method of VTE prophylaxis. Early walking has been associated with lower incidence of post-total hip replacement symptomatic VTA, while in combination with motor physical activity, it can be associated with early return to community, shorter hospitalization time, fewer complications, and lower 6 months mortality rate. However, it must be noted that although the early and frequent ambulation of hospitalized patient at risk of or for VTE is an important principle of patient care. The majority of hospital-associated symptomatic VTE venous occur after patients have started to ambulate. Therefore, mobilization alone does not provide adequate VTE prophylaxis for hospitalized patients and should often be regarded with caution. Now we're going to shift to pharmacological VTE prophylaxis. The option of pharmacological VTE prophylaxis include aspirin, unfractionated heparin, low molecular weight heparin, adjusted doses of vitamin K antagonist, and synthetic beta-saccharide factor 10 active inhibitors like fondaparinux and newer oral anticoagulants. We're gonna speak a little about aspirin, the mechanism of action of aspirin that inhibit platelet aggregation through antagonize one of the catalytic enzyme of platelet activation or particularly aggregation. I believe is TGA1, one of the catalytic enzyme for platelet. Aspirin inhibits this enzyme. The advantage of aspirin is inexpensive. Number two is orally administered, which is increased compliance. Number three, widely available medication. With controversial use as prophylactic agent for VTE in 2008, American College for Clinical Pharmacology guidelines clearly recommended against the use of aspirin alone as VTE prophylaxis for any patient group, and therefore for any orthopedic patient. However, the 2012 ACCP guidelines do recommend the use of aspirin as VTE prophylaxis for patients undergoing total hip replacement, total knee replacement, or hip fracture surgery, because it appears that the use of aspirin for VTE prophylaxis in this patient is more effective compared with placebo. Nevertheless, the same guidelines, the use of lower molecular weight heparin for the other recommended agent include aspirin is concluded. And to be honest, while I was searching for this topic, I found that low molecular weight heparin is most recommended pharmaceutical agent for post-orthopedic prophylaxis. We're going to talk about vitamin K antagonist. Is a group of oral antagonist whose anticoagulation effect is produced by interfering with cyclic interconversion of vitamin K and it is 2,3-epoxide, thereby modulating the gamma carboxylation of glutamate residue within the epoxide enzyme on the N-terminal region of vitamin K dependent protein. Two common vitamin K antagonist drugs are ethinocomerol, I believe it's one of the warfarin's derivative. Mean half-life is 9 hours, ranged 8 to 11 hours, and warfarin, number 2, mean half-life is 2.5 days, which is long half-life. The use of vitamin K antagonist requires monitoring, and the most common way to monitor vitamin K antagonist therapy is through thrombin test. This test provides information about PT activator or activity through the measurement of international normalization or normalized ratio INR. The other class is unfractionated heparin, is a heterogeneous mixture of glucose aminoglycan that bind to antithrombin via unique beta-saccharide sequence and catalyzes the inactivation of thrombin. And therefore, factor 10 active and other clotting enzymes. The heparin antithrombin complex inactivates thrombin, which is factor 2 active, and factor 10 active, factor 9 active, factor 11 active, and factor 12 active. so that inhibit thrombotic formation or thrombus formation. Unfractionated heparin also must be administered. We're gonna talk about the administration of heparin. Should be administered parenterally. Since it's not absorbed orally, the two preferred administration routes are either continuous intravenous, IV infusion, or subcutaneous. The subcutaneous administration is associated with reduced bioavailability, and therefore a higher dose compared with IV administration is required in order to overcome this difference. If an immediate anticoagulation effect is needed, an IV bolus injection of heparin could be accompanied the initial subcutaneous administration. The use of unfractionated heparin may lead to hemorrhagic complication. This risk increases with the amount of dose and the concomitant administration of fibrinolytic agent or glycoprotein 2B3A inhibitors. Additionally, recent surgery, trauma, invasive procedure, or concomitant hematostatic defect increase the risk of bleeding. Because anticoagulant response varies among patients, monitoring unfractionated heparin with test and adjusting the dose is a standard practice. I believe I talk about the side effect of heparin, which is hemorrhage, other increased amount of dose. Okay, we'll go to the other slide. We're going to talk about low molecular weight heparin. Is derived from unfractionated heparin by chemical or enzymatic depolymerization. Their molecular weight approximately 1/3 of that of unfractionated heparin. Low molecular weight heparin has more favorable benefits to risk ratio in normal or animal models with superior pharmacokinetic properties. That means work in your body, but better than the unfractionated heparin. And the inhibitory activity of low molecular heparin against factor 10 active is greater than thrombin and exhibit less bind to cells and protein than unfractionated heparin. Consequently, low molecular heparin preparation have more predictable pharmacokinetic and pharmacodynamic properties, also a longer half-life and lower risk of non-hemorrhagic side effects than unfractionated heparin. Low molecular heparin also is administered subcutaneously via injection in 1 or 2 daily doses without the need of monitoring. The use of low molecular weight heparin is more convenient than unfractionated heparin and thus has replaced unfractionated heparin for almost any clinical indications. Fundabarinox is synthetic pentasaccharide with a molecular weight of it's okay to skip it. A specific anti-factor 1 activity inhibitor that is higher than that of low molecular weight heparin. His weight, I believe, and a half-life that is longer than low molecular weight heparin. After subcutaneous injection, there is a rapid and complete absorption of fundabarinox. A steady state is a steady state. That means it's going to be stable in the plasma and the tissue is reached after the 3rd or 4th once daily dose. Fundabarinox is excreted unchanged in the urine with a terminal half-life of 17 hours in young individual and 21 hours in elderly. Okay, we're going to go to newer oral anticoagulant. Compared with vitamin K antagonists, the newer oral anticoagulant drugs have the advantage of ability to administer at fixed doses without the need of laboratory monitoring. Subsequently, they have potential to overcome several drawbacks of vitamin K antagonist. We're going to talk a little bit about rivaroxaban, an orally administered direct inhibitor of active factor 10. Rivaroxaban received marketing authorization at 2008 for VTA prophylaxis in adult patient undergoing elective total hip replacement and total knee replacement. It was found to be more effective than enoxaparin in prevention of VTA after total hip replacement or total knee replacement in phase 3 trial or clinical trial. Rivaroxaban is administered in a fixed daily oral dose of 10 milligram for VTA prophylaxis after elective total hip replacement and total knee replacement. Also, the guidelines recommended rivaroxaban as a method of VTA prophylaxis in patients undergoing total hip replacement and total knee replacement. However, the same guideline report that rivaroxaban has not been evaluated in hip fracture surgery. Therefore, rivaroxaban currently is not recommended for hip fracture surgery. Dabigatran is a selective reversible direct thrombin inhibitor. It is administered as dabigatran atixylate, which is an orally absorbable prodrug. Since dabigatran itself is a strongly polar molecular that is not absorbed from the gut, phase 3 clinical studies evaluate that the use of dabigatran atixylate for VTA prophylaxis after elective total hip replacement or total knee replacement for the treatment of VET and for prevention for stroke or symptomatic embolism in non-valvular atrial fibrillation. The drug has been approved in many countries for VTA prophylaxis in patients undergoing total hip replacement and total knee replacement. This is my reference, National Library of Medicine and Science Direct. And as I said before, all of the references that I found suggest or advise to use low molecular weight heparin for pharmacological prophylaxis for post-orthopedic surgery, DVT, and pulmonary embolism prevention. Thank you for listening, and thank you so much. If you have any question, do not hesitate to ask me.
Thank you, Dr. Hamida. Anyone has a question for Dr. Hamida? You can write it in the chat or use the mic.
Now I'm gonna stop sharing. Thank you.
Again, thank you so much for great presentation. Excellent. Thank you for you. If any additional questions to Dr. Hamida or Dr. Monir for the previous presentation, if you have any questions. No questions, we can go to the next topic in the agenda. And before I go there, I'm going to present the
we can, yes, we can.
Yeah.
If there's no questions, we can continue with Dr. Abdelrahman for the OpenAI present.
So I'm going to present first topic. One of the things that for the new fellows, and I want to share with you that we can use the app. So when you start the app, there is upcoming Zoom meetings and previous. If you want to look at what we did in the past meetings, you can watch some of the previous last week, the week before meetings. It's recorded, and you can see who presented, who was the moderator for that meeting. For the upcoming meetings, we have some teams listed. So the green team will be presented next week. So for example, if there are numbers of fellows in that team that are ready to present, they can pick up some of the topics and then divide the task between them. Usually the team leader will be the moderator. in certain cases, like today, the team leader is not available. So we asked one of the other team members to moderate or to use the team or the Zoom meeting. But otherwise, you work in team format, like each team member we expect to participate. If you have some reason not to participate, communicate that with your team leader so that at least we know if we have enough presenters or not. In case that we don't have enough presenters, then the team leader or the responsible fellows in that team can discuss or open the floor for other fellows in the fellowship. So whoever is available to discuss some of the agenda for next week, for example, they can participate, so they can volunteer. We don't limit it to that team. It's just organizational, so that everyone has a chance or opportunity to participate. But I know some of you might have some other obligations, or they work during the weekend, so they may not be available. So I just want to share this part with you. And the other part is when you open the agenda, you can edit that, so you can add your name using the pen there, and we'll discuss this in the coming weeks or so. Going back to the topics of today, so artificial intelligence, we can use it, for example, to use it in this fellowship. I'm going to take an example for you. 2 days ago, there was a grand round in neurology. I missed that, and the topic was open publications or open access versus subscription journal publishing. So that topic was very interesting. I was very interested in that topic. So I asked them to give us an access to the recording for that rundown. However, the person who is taking care of that recording is off. So I started to think about who can help. So I went to the AI. I'm going to show you. So we will go to Bot. It's like ChatGPT, and there are two of them. Bot.google.com is from Google, and then GPT and GPT-4 are different group or different companies. So I stopped using this one, so I asked the question, can you make 15 presentation slides regarding the topic? So I want to see if they can help me, the AI help create these slides. So this is the topic. So the title could be Open Access with Standard-Based Publications, and the introduction, some questions, open access, some definition, and then funding models, some details about licensing, some standard subscription-based publication, what the definition, what the benefit and disadvantage of that model. So here's the comparison between the two, open access and subscription-based, and then the future of open access and some advantage of open access for the researcher. And some challenges are listed here, and initiatives supporting the open access also was listed. So in conclusion, the AI helped me that open access is transformative model for scholarly publishing, or it's very helpful to researchers. It offers many benefits, and I think it's the future in that direction. So what's the last two slides, but the take-home messages. And here are some of the references, so I can add some of the references. This is previously what the answer was given to me using AI. If I don't like that, this is just a draft, so I can use a different draft, and it will change some of these slides. And here's another one. So this is how you get your slides, the text or the content of your slides. So I went further. I asked the ChatGPT to maybe give me, I'm going to show you here. Then we'll speaker notes to the slides above. So I can ask to have some of the slides with some speaker notes. So as you can see, we got some of the instructions as far as what you do with each slide. But here I can, as a professor, can add the note in the speaker. So I can specify a role for that AI to help me what exactly I want to say. So here's the so it's kind of instructions as far as how you introduce yourself, and then so here's the role for the professor or something like that. So you can identify or tell the AI a role to play, or so you can ask academic tone, something like that. So it can show you some of the sentence or how you add some of the information. In any case, so the first time you had it, you can copy that. So I can go here, I can copy that into and share it or export it into a Gmail chat and the mail or as a document. So I'm gonna share it or export it as a document. It will open a document where it has the content of the slides. So you can open the document and then you can see slide 1, the title, and slide 2, whatever questions, and you have the table here, the difference. So to create slides out of this, there are different ways. One of them, you can ask Google itself, it can help you, or some of them you can go to like presentations.ai. It has a free option to help you create some slides. And then you can also use different presentation tools like this one. It has some simplified.com, for example. It has some options for you. So you ask the same question and ask about AI, open access, there's a subscription journal publishing. So you go next, and here you can select what theme I want something of this type, and you go and generate that. So it will generate the 14 or 15 slides for you, or maybe different. So this is slide number 2, definition, and then pros and cons, comparison between both of them, and so forth. So you can get that done in a few minutes. So you have the conclusion, and you can edit all these slides. So you go up, whatever slides you want to do, you can add your name, add the references, or so it's kind of so you can edit the slide, and if you want to go up and down, you can go down or up, whatever slides you want to edit, so that you can also modify all these slides. If you don't like it, you can go back and you can find a different theme with the same topic. So there are options for you, or tools out there, and some of them are free, some of them are kind of depends on expensive. So this is how you create slides using AI. So you go to either Bard, for example, or ChatGPT. It will give you the template of the actual content. You can update that if you have more references, and then you can use different tools to help you get the slides done. Or you can use slides or the tools that create slides with the question that you want to ask about the topic. So this is kind of a brief introduction about AI, and that's how we can use it for certain topics. Another way of doing it is you can search the web, let's say google.com, and what I do is I can put the question, and I want to look for PPT, that's the PowerPoint presentation template. So you can get some already made on the topic, the same topic. If you open here, you can get some these slides, let's say 40 something slides there, and these were done a decade ago. To 2010. So you can look at it and see if that also helps you. If you want to have a different one, you can get some from some of the universities, and for example, this one is from Pittsburgh University. So it's an actual PPT or PowerPoint presentation slide. So if you click on it, it will download the file for you, and then you can edit that as PowerPoint file. So there is this way of searching the web. If the topic is already done, for example, you can search for PPT. If you want to create your own, you can ask Bart to help you create how many slides you want, and you can set your tone. You can use certain other tools like the one with presentations.ai that also can help you create these slides. So this is shortly way of getting things done. Thank you so much. Any questions? Any questions or suggestions? So I'm going to talk about the screening or how to capture the screen. So in Windows, for example, there are different ways of also recording the screen. If you click on the keyboard, on the top part of the keyboard, you will find F1, F2, F3, it has numbers. At the end of the numbers F12, after that you will have a key where it has print screen. But in Windows 11 and the newer version of Windows, you can hit Shift, Window, and I believe S, and it will help you define an area. I'm gonna share the screen to show you. So let's say this is the agenda for today. I want to copy this part and I want to add it to some text, for example. So I'm gonna hit Shift, Window, and S on my keyboard in Windows. It will identify the mouse will be like a plus sign, and I can identify or can get the range that I want to capture, and it will be captured. When I want to add it to, let's say here, I can copy paste. So just paste it, and it will be done or pasted in the place where you want it. So this is one way to record the screen as a screenshot, only just one image. And you can do that, for example, someone is presenting or you have a video that's going, so you can just do whatever area you want to capture. You can screenshot that area, and it's easier for you to capture some of the images. That's still image or just one photo at a time. What happens if you want to record the whole recording? So there is another way to do that. So I'm gonna share with you just a second. Go first. I'm gonna share it again. The screen. So I'm gonna go to the app. So if you go to the app, we have some files or some videos. So if you go down, we added some of the videos here. So this is one video that has some recommendations of 5 best free screen recorders. If you go there, you will have the file of the video. It's a YouTube video. So if you want to click on it, and you can
You are muted, Dr. Nader.
So in my computer, I can use my Windows keyboard. So Window, Alt, and R. So it's gonna be. I don't know if you see the computer. Maybe it's not gonna show you here. For some reason, it's not gonna show me. I'll show you there. So if you hit on LT Alt, Window, and the letter R, it's gonna be opening the recorder from the Windows application. Or if you hit down here, search for gain bar, and it's gonna get you a bar where you can record certain things. So this is one way of doing it. In the video, they show you Zoom. You can use Zoom to record a certain, let's say you want to record yourself, or you want to record a video of one site like YouTube, or if you want to illustrate something, but you want to record that in your computer. So you can do that using Zoom. So you don't invite other people, just create a Zoom meeting, and you will be able to share the screen and demonstrate or do your recording there. And different one is screen recorder, and that's online. You can use that, and there are other free online screen recorders. So this is how you can get some of the recordings, either as images or as videos. So when you download or when you save the recording, you can use that in the later. For example, or you want to add that, edit that, you can do that as well. Any questions? If no questions, I'm going to share with you in the chat. We can go to the next agenda item in the updates. So I shared you a link for the webinar we just did, group of fellows, and they presented or they did great work today. We have some guest speaker as well regarding the COVID and its effect, so long COVID and its effect of musculoskeletal, neurological, and cardiovascular system. So if you want to look at that and you want to watch the recording, it's going to be there. We use YouTube and Zoom, so it's going to be on the online. Thank you for the fellows who did that. Any questions or any updates as far as your projects, guys, or comments, suggestions? So this is the title for the webinar that was done this morning. And you can click on the YouTube video, or I think you can get the video also somewhere here where we did it. Any updates as far as your research projects? If you have any research questions, or if you have any projects going on. I know some of you are working on different project manuscripts or abstracts or app development. So how are the interviews season for you? Hopefully I hear good news about if not all of you, some of you might have good interviews and hopefully March we will hear good news.
Thank you, Dr. Nader. Thank you so much.
So any questions about the fellowship itself, about what we are doing, and how we can improve, or anything unclear about the presentations of today? So Abdelrahman is asking if there are any projects that are going. So in the start group of WhatsApp, you can ask that question, but we have at least a couple of projects going, and we always create new projects. So if you are interested, I'm gonna send you an email with more instructions. Send me an email, please, and you can start working on some of the projects, either the old ones or the new ones. Ryan, go ahead. Thank you.
Assalamu alaikum, Dr. Nader. Thank you. And thank you for sharing the webinar. So my team and I, we had an amazing webinar earlier today on the effects of long COVID. And throughout the research regarding the effects of long COVID, we focused on adults. I came across a lot of information related to pediatric long COVID. And so I was thinking of potentially doing a second webinar, and I was hoping people who are interested in applying for pediatrics could reach out to me. That way it's within their field, and also being able to work on the webinar with us, inshallah.
Excellent idea. Thank you so much. And Dr. Ryan and Shafti did a wonderful job today. So if you want, you can reach out to her and maybe create a panel of speakers, and then we can see if we can invite some specialists. Thank you. And in the past, we had a presentation of how you can organize a webinar, how you get the speakers, how you plan ahead, divide the topics, or the topic itself divided into small subtopics, and identify who will do what. So that can be also arranged in different topics that we can discuss in the future. So that one way you can identify an important topic and present it as a webinar. So it's gonna be a teamwork, and we can also look at how we, for a technical aspect, how we can coordinate that on the day of the presentation. Thank you.
Thank you, Dr. Nader. And thank you, everyone, for attending. And Dr. Rayyan, if you can share the time or a link with everyone. I see a lot of people are interested in the webinar.
Yeah, so I'm hoping the people who are interested, again, I want to target it towards those who are applying for pediatrics. So when we initiated the webinar for adult long COVID, there was only 6 of us. So it is going to be a smaller group. We can easily add more people, but I want to make it specific to those applying for pediatrics. So I'll reach out to you guys on the WhatsApp group, and hopefully we can arrange it. Again, if possible, guys, just those who are applying for pediatrics. Okay, thank you so much.
Okay, thank you, Dr. Ayan. Any more questions for Dr. Nader?
Thank you, Dr. Fawad.
So in the past, we discussed about the posters or abstracts that submitted to conferences, and we were successful. So we can continue doing that. And different conferences that are available or open for submission. And the idea I want to share with you is we can convert some of the posters in the past into manuscripts or into papers. So if someone is interested and have some time, we can identify which area you are interested in and see which of the posters that presented or abstract that accepted, and we can convert that into manuscript. So you need to work on getting more information, maybe more literature review, look at references and so forth, so elaborate a little bit, and then we can convert that and we can submit that into, we can submit it to certain journals in the field. Hopefully that will help. Even if we are not successfully submitting it, the work itself will be a way of improving your skills. So if you finish the project, you can know how to start, how to finish. You can start on something different and you can work on that as well. So that's something to think about. Any other questions or comments or suggestions before we end the meeting? No, then I'd like to thank all the presenters from today. Thank you so much, Dr. Salal and Hamida, for great presentation. Thank you all the attendees, and also thank you, Dr. Kra, for moderating this meeting. I wish you all the best, and we hope to hear good things from those who are applying this year. Thank you.
You're welcome, Dr.
Assalamu alaikum.
Thank you. Thank you so much.
عليكم السلام ورحمة.
Thank you, Dr. Nader, and thank you everyone for attending.
Thank you, Dr. Nader.
Thank you, Dr. Nader. Thank you all.
Thank you, Dr. Nader.
Thank you so much.
Thank you so much.